The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, TMD warriors. I'm Tony Urbanek, and we're here for the next episode of TMD Demystified. It is my pleasure to be here with you today, discussing a very technical topic, which was triggered by an experience I had yesterday. I have no idea how long this particular episode is going to continue, but I'm hoping certainly it's less than 30 minutes, somewhere between 20 and 30, and I invite everyone to focus on this topic. It is very important when it comes to understanding and treating correctly the problem of TMD. So let me go back a little bit and discuss a little basics that go into this. But the title of the topic today will be something like functional malocclusion and TMD. Functional malocclusion and TMD. What I found, I don't think I discovered anything, ever, never. What I found and continue to find on a daily basis is that there are only three causes for the temporomandibular joint problem, direct causes, and then there's the common denominator. But the causes are bruxism, which causes chronic inflammation within the temporomandibular joint, acute trauma to the face and the jaws, which causes acute trauma, eventually leading to chronic inflammation of the temporomandibular joint. And the big one, which is badly misunderstood, badly treated, misdirected, is functional malocclusion of the maxilla and mandible. Now, my orthodontic colleagues are much well versed at treating, understanding, and knowing about moving teeth. But what I have discovered is both my general dental colleagues and my orthodontic colleagues frequently miss, and not 100% of the time for sure, but frequently miss the concept of a functional malocclusion causing or developing temporomandibular joint disease and causing eventually, sooner or later, chronic inflammation, which leads to all the symptoms. So here's the progression of things. You have three, and only three. I have never seen any other direct cause of inflammation within the joint that don't fall in these three categories of bruxism, clenching and grinding, acute trauma, and functional malocclusion. All of them leading eventually to chronic inflammation within the temporomandibular joint. And as we now know, that is the common denominator and direct cause of all of the symptoms. The direct cause is inflammation, and inflammation will cause headache, earache, jaw pain, neck pain, tinnitus, subjective hearing loss, vertigo, shoulder pain, arm, hand, finger tingling, and numbness, and various types of locking of the mandible. Okay, so we're going to focus today on one area of that, which is functional malocclusion. And again, which I've stated many times, when I got into this with the intent of just trying to figure out a solution, a real solution, trying to figure out why no one else had a solution that actually worked, a workable solution, coming from the surgical sciences and knowing that at best surgical treatment was hit and miss, and of course experienced many patients who came back after surgery and continued to have symptoms. Not all of them, but many. And I attempted to figure it out, which we did, and we figured out that the common denominator is inflammation. And then we had to delve into, okay, what causes chronic inflammation? Now, the one that we want to talk about today, functional malocclusion. When I first started coming from the surgical end of this, surgical sciences, my concept of a functional malocclusion was a large, significantly big class 3 or class 2. Mandible set way back here, maxilla set way out front, total big class 3s of the mandible. Oral maxillofacial surgeons experience that those types of patients would frequently end up with significant jaw joint problems. But I have been disabused of the fact that you can't classify it just as in large, obviously visually large dysfunction, displacement of the maxilla and mandible. What I've found after treating thousands of patients now, well over 3,000 personally, and now we have doctors throughout the United States who are doing the same thing through our network, is that what I used to consider a minor meaning 2 or 3 millimeters, maybe 4, can and do cause significant functional malocclusion to the point that it overloads the temporomandibular joint and creates chronic inflammation, leading to the symptoms. And then once I saw that enough, then it became apparent that there were major misunderstandings, miscommunications within, and training, and especially training within our dental community, starting in dental school, where our young dentists who are either go through training into general dentistry or into the specialists have little to no understanding of how functional malocclusion can cause damage and its detrimental effects on the joints themselves. This episode today was triggered by an experience I had yesterday. I have no problem coming up with topics for this because they all come out of my experience on a day-to-day basis seeing patients. And yesterday I had an experience with a young woman that I treated. I have a chart here in front of me. I don't need to go into it in detail, but a young woman that I had treated years ago with a device going back to 2017. And her initial symptoms were, I'll read them back to you, right and left temporomandibular joint pain with headache, earache, jaw pain, ringing in her ear, tinnitus, fullness in her ears, vertigo, shoulder and arm pain, and did not have any locking experience. But those were her symptoms. And we treated her with good response. And I saw her up until the end of 2017, and we ended up with 95% of her symptoms gone. I did my final discussion with the patient about how to carry on from that, and I discharged her to return PRN. I had not seen her for 3 years, and she came in yesterday, and with this history, she went to her general dentist, a younger general dentist, and she came in, she said, I was starting to have pain again. I think she pointed to her left side, and she mentioned it to her general dentist, and she hadn't been having symptoms long. It was just a matter of a few weeks. And she said, my general dentist told me that she looked at my bite and she looked at the device, and she said, I think the device is causing your teeth to move. And she says, I'm only hitting on 3 molars in the back. That's what my dentist told me. This is what exactly the patient said. And I pretty much knew at that point what was going on. So, but I verified. I looked at the device, and it was in perfect condition. It looked like it was almost brand new from the time I developed it. She had taken good care of it, kept it clean with toothbrush, toothpaste only. And it had separated her back teeth normally. There was no super eruption of the posterior teeth. But what this patient had, very obviously, and it was obvious to me back in 2017, and I had mentioned this to the patient, that this patient had a verified functional malocclusion. She had maxillary excess, and being the maxillofacial surgeon I am and done a couple thousand orthognathic cases in my career, I can literally sit across from a room and pick up, is the mandible too far forward? Is the mandible too far back? Is a maxillary excess? Is a vertical excess? Too much vertical growth of the maxilla, which is very common. Maxillary problem of growth. And what this patient had experienced was that the device, as always does, takes the patient back to centric relation, where the condyle fits well in the glenoid fossa, unloads the joint, allows the inflammation to go away, and her symptoms go away. And that was her continued experience. But when she went to her general dentist took a look at her and thought that the device was causing her somehow her maxilla to move forward. Well, no, she had a growth problem from the get-go, starting in adolescence, of maxillary horizontal, not so much vertical, maxillary excess, and that she had actually compounded her joint problems by, through growth and adolescence, learned to hold her mandible forward to get her teeth to fit together so she could chew, but developed significant temporomandibular joint symptoms, which were totally relieved when you allow the mandible to go back to centric relation. And in her case, the difference between CO and CR was not huge, and her maxillary excess was not observable by most people. By a maxillofacial surgeon, yes, it would be obvious, but to most people on the street, they would say she looks kind of like normal facial contour, normal face, but it wasn't recognized by the general dentist at all. And this is just an example. This is not the worst example that I can think of. It happens almost daily, certainly weekly in my practice, where the general dentist does not appreciate, or sometimes the orthodontist does not appreciate, that a significant CO-CR discrepancy, whether it be due to growth early on or whatever, is contributing to the temporomandibular joint problem. And it's all about education, and that's what I'm all about, and it's what our company is all about, is educating certainly not only the patients, in fact, primarily the doctors, to recognize, number one, that inflammation causes all of the symptoms of TMD, and that if you can get rid of the inflammation, it makes the symptoms go away consistently. But the topic today is recognizing significant, as little as 2 or 3, well, two's excessive, 3 to 4 or 5 millimeter difference between CO and CR can tear up the joints. And to recognize that, and to recognize that in a lot of patients, something needs to be done about that, not just to say, hey, and our colleagues are always looking for things to do. No one has all the patients they want to have. And enlightening our dental colleagues that once you recognize the problem and solve the immediate symptoms, immediate can be any number of those on the list, that the next step is to take away or remove the causative factor. In this case, causative factor being functional malocclusion. Now, of the 3 causes, an initial trauma, a beer bottle to to the mandible 4x4 off the back of the pickup truck. You're not going to, you can't duplicate that, or you can't, go back and say that didn't happen. Bruxism, we have no answer to. And I tell patients all the time, and I think I did a rather extensive presentation on this in previous episode, is, don't tell patients that we know how to keep them from grinding their teeth, because we don't even understand the mechanism. Have no idea. The only thing we know about bruxism is that it is related to stress. More stress, more people tend to clench or grind their teeth. That's all we know. We don't know the mechanism. It's all in the central nervous system. You might have some theories. You could say, well, if it's in this part of the brain stem and the autonomic nervous system does such and such, okay, I can have that. But we really don't. We don't understand completely the mechanism that goes on between stress and bruxism. And you're not going to get people to stop. I have never, ever seen anybody to stop bruxism. I've seen improvement when they relieve some of their stress. Exercise is helpful. Staying away from bad things like a lot of sugar, a lot of alcohol, all those things are helpful. But once people brux, they brux. So you can't control bruxism. You can't go back and replace an acute trauma, but you can fix a functional malocclusion. We can do it all the time in the technology that we've developed since I was in dental school. And I was on the cutting edge of the development of orthodontic surgery. I was witness to significant improvements in orthodontics since the late 70s, early 80s. Like orthodontic colleagues have, done tremendous improvement in their technology, distraction orthodontics, distraction osteogenesis, and of course, being able to use dental implants and being able to combine all of these different modalities of treatment, surgery, non-surgery, orthodontic, occlusal harmonies, to give patients a occlusion, a functional malocclusion, where the centric occlusion pretty much matches the centric relation. The ideal scene is to have CO equal CR. That is the position that will cause the least trauma to the temporomandibular joint, or you don't have a lot of sliding. You don't have to hold your mandible forward to get your teeth together like this young woman did for most of her young life, which got her to chew, but tore up her temporomandibular joints. So the primary purpose of this episode is to bring this to your attention, those that listen, those that want to fix this for their own patients in their own practices. And number two, to get away from the concept that whatever kind of hammer you have in your hand is the only way or the proper way to fix it, because a lot of these cases take a combination of services. I've always felt that. I never felt that surgery was the ultimate answer to fix a functional malocclusion. I always ask for the assistance of orthodontics. I don't think I've ever done an orthognathic case where I didn't have orthodontic assistance. And even today, there are centers and people who claim that they should and could do orthognathic surgery, move the jaws around without the help of an orthodontist, and that doesn't make any sense to me. And of course, occlusal changes using crowns, bridges, dental implants to bring the patient to the ideal scene where CO equals CR. That is ideal. So functional malocclusion turns out, as I found out, as I've gone through this 10-year period of learning for myself, functional malocclusion is a huge, huge discrepancy in dentistry in understanding the effects of functional malocclusion, not just on the teeth themselves, but especially on the temporomandibular joint. And of course, you can bring it into patients' function as far as what they can chew, how easy it is for them to chew and eat their food. But the other effects on the other symptoms, which come through violently sometimes when they have this problem. This applies to all of the areas of dentistry. It applies to general dentistry, like this example I gave from yesterday, that the young, I know she was a younger general dentist, had no understanding of what was going on here. She just commented, which, kind of puts me in a little tight situation, but I've seen it multiple times. I have no problem with it. You have to, and the answer is you explain in detail to the patient pretty much what I just explained to you, that everybody has 2 bites. There's not a patient on the planet that doesn't start out with some kind of difference between CO and CR. I don't think I've ever seen anybody who naturally has an exact CO equals CR. And if they're mild, if they're within, a couple millimeters of one another, everybody gets by. It works pretty well. A little bit of sliding. That kind of bite does not overload the temporomandibular joint. But if the patient has to hold their mandible forward to get eccentric occlusion so they can chew, pull the condyle out of the socket, which distracts the meniscus long enough and beats up the meniscus long enough, create chronic inflammation, off you go into TMD symptoms. The next point I want to make about this is to talk directly to my orthodontic colleagues, because again, I get to see the ultimate experience and the result of different types of mandibular traction. I'm all for moving teeth, and I thank God we can move teeth through bone, but to put traction on the mandible to try to pull it forward, even in adolescence, especially in adolescence, does terrible things to the temporomandibular joint. If you want to learn more, I mentioned this resource and reference before. Donald Enlow has the textbook on facial growth and development, and I'd recommend anybody who really wants to learn about facial growth and development to read Enlow's textbook. He's had several editions. First edition I read twice in the late 70s. Changed my attitude and actually changed my career and emphasis on orthodontic surgery and how I thought about it and how we did it. It really describes how the temporomandibular joint itself is one of the primary growth centers of the face. And theory is that you can pull on the mandible and stimulate the growth of the mandible. That is not necessarily proven. But what we do know is that, what I have seen multiple times, hundreds of times, that different types of traction devices, external head frames or herps devices, anything elastic that pulls the mandible forward at any time during growth and development can damage the temporomandibular joint to the point where sooner or later you start to have symptoms. And I mean, the examples are, patients will come in, mom will bring Janie in, age 15 or 16. She's having terrible headaches every morning, every night, headaches, earaches, jaw pain. And I say, have you had orthodontics? Or I can see on the Panorex, so you got internal retainer on, he's had orthodontics. I said, did you have any kind of traction on your mandible? Oh yeah, I had herps, or I had elastics that pulled my mandible forward. And now this young person is in the temporomandibular joint symptoms of significant degree. These should be obvious. This is obvious. It's obvious and should be obvious to all orthodontists, but it's not, because I keep seeing it, unfortunately. And I'm trying to actually correct that. Sooner or later we will, because the truth gets out, and what works works. And so I wanted to kind of unpack and specify some facts and observations about the relationship between functional malocclusion and inadvertently caused or caused just through normal growth and development that causes temporomandibular joints. Because I see it increasing. I don't see it decreasing. I see it increasing, maybe because my observations potential is more. We see more patients all the time, and I'm more tuned in to actually looking for it. And the more I look for it, the more I see it. And the point I wanted to make is, if your only treatment is orthodontics, it may not be the only treatment to use. If your only treatment is functional rehabilitation, where you crown every tooth in the mouth, but you have a significant difference, a significant difference between CO and CR, you may really better off having an orthodontist treat that, or in a lot of cases, which are avoided from the patient's point of view, the family's point of view, orthognathic surgery. And again, I was on the cutting edge of orthognathic surgery as developed in the late 70s. And, we used to have to have a couple units of blood drawn up every time we did a double jaw case, maxilla and mandible. And at the end of my career, I was doing them outpatient, double jaw cases outpatient. Didn't have any problems. Potential there is, but certainly we didn't have to have 2 units of blood drawn up, and it was, instead of a 5-hour operation, it was an hour and a half, maybe hour 45 minutes. So it's not, as the technology rolls out and the experience rolls out, these modalities are best combined to make it streamlined for the patient when necessary, who has a functional malocclusion, which has now gone into temporomandibular joint symptoms, which ruin their lives, to use all the modalities necessary as appropriate and factor them on in to actually solve the CO-CR discrepancy, to bring them as close as you can within reason to a CO equals CR. And that gives them lifelong support for diminishment of their temporomandibular joint symptoms. So the last point I want to make about this, I already commented on it, and this needs to start in dental school. I don't know how best to do that. I'm actually on some trails and some discussions and some communication lines to do that. And I've started that process. I know the constraints that dental schools have and how much information they need to get across in a period of 4 years. I went through it myself in a time where there wasn't even anywhere near the amount of technical information that is available now. So I understand the problem in dental schools, but it spills over in the specialty programs. It spills over in the oral maxillofacial surgery specialty and the orthodontic specialty for sure. In that the correction of functional malocclusion is much more important and critical than we used to think it was. And to get that point across, we're not trying to make orthodontists or oral surgeons out of 3rd or 4th year dental students, but they need to get the message that these are available and that might even lead some of these younger people into the specialties that we need to help. And we need progressive, knowledgeable people going into the specialties who are able to critically think and look at the situation and crank in the best treatment overall for the patient. So that's my summary of the problem of the relationship between temporomandibular joint problems and functional malocclusion. I hope it was meaningful. I hope I made sense. I look forward to any comments or criticisms or anything you'd like to talk about, anyone who's watching, because I want to solve this problem of TMD in the simplest way. And now we know we have a non-surgical correction to vast majority of people with these symptoms. We can exclude a huge amount of surgery being done. We can exclude a huge number of diagnostic x-rays, a huge amount of expense, huge amount of things that do not work or only work very temporarily. We can exclude all kinds of treatment that actually have detrimental effects on the patient one way or another: drugs, surgery, Botox, and do it in a way that helps everyone, helps the profession, encourages patients to think much more highly of the practitioners, and keeps us all moving in the same direction, developing our services as both dentists and physicians and health providers. So for today, I've kind of finished my presentation. I appreciate your attention. As always, I look forward to speaking with you in the near future. I am Tony Urbanik, and this is TMD Demystifies.